sure everybody's been on the edge of their seat just waiting for the exciting conclusion of early pregnancy pearls. Part 2, wait no longer. It's here. It's here. This actually is a pretty short section. There's only 6 or 7 abstracts to go through, so there's lots of time for questions if you guys have any. So start of this section starts out with an ACEP policy comment saying emergency physicians frequently evaluate and manage patients with abdominal pain and or vaginal bleeding in the first trimester of pregnancy. The primary concern in this group of patients is to identify what disease process? Ectopic pregnancy. Generally, that's all we really care about, and a lot of this section is devoted to that topic of ectopic pregnancy. So the first 3 abstracts talk about the use of pelvic examination in the emergency department. I'm just going to say up front that these are just 3 different people's opinion. These are 3 authors' opinion that go through some studies, and I don't really agree with any of them, with any of these 3 authors, just because intuitively it doesn't make sense to me. Because what they're all saying is that in the era of the ultrasound and the beta HCG, you have your quant beta, the utility of a pelvic exam is essentially nil. This just seems like a really difficult pill for me to swallow. And I'm not like I'm crazy about wanting to do a pelvic exam or something. You know, I just think it's relatively necessary. It doesn't make much sense to me if a patient comes in with pregnant vaginal bleeding to not look at the source of the bleeding. You know, I think about it like I would some other disease process. Like let's say there's some patient who came in and they tell you that you know, they're working on something in their garage and they cut their shoulder. There's a cut on their shoulder. And they got all nicely bandaged up in triage. You know, you just ask them some questions. You say, all right, well, is it still bleeding? Well, I don't think so. You know, bandages on there. I don't see any bleeding. Well, how deep did it go? I don't know. I have no idea. You know, well, it's not bleeding now. Your sensation's all okay in your arm. I'm just going to discharge you and send you home. It's like, whoa, don't you want to take a look at what's actually bleeding? Like, I came in because something specific is bleeding. Don't you want to look at it? No, I'm good. I'm fine. It's not bleeding now. Problem seems to have fixed itself. Like, I kind of see this whole thing the same way, but that's not how these authors see it. So the first one is a pretty large review, actually, of 43 different reports on this topic. And the conclusion of the authors is saying, we essentially hardly ever find anything with the pelvic exam, with the speculum exam. So unless the patient is sick, I wouldn't do it. Second paper, second abstracts, it's really small. It's a prospective observational study looking at 50 pregnant women with a viable IUP on ultrasound and a beta HCG that seemed to match dates, and said, okay, let's do pelvic exams on everybody and see if we find anything. And their conclusion is they didn't really find anything that impacted the management of these 50 patients. But wait, one of the patients had chlamydia. Pus was noticed on their speculum exam. That's 1 out of 50. It doesn't seem to me like they didn't find anything. It seems to me like they found something in 1 out of 50 patients that they weren't expecting and wouldn't have been detected by the ultrasound and quant beta by itself. The third one is a prospective British study of about 250 patients. Some of them, almost all of them didn't get pelvics, but a good chunk of them didn't get ultrasounds either. Right? This is a little bit scary. And they said, like, we sort of followed everybody out of the long term and everybody did fine. And generally, I kind of understand that. We see a lot of first trimester bleeding. We get a lot of ultrasounds. We get a lot of quant betas, and we don't often do anything. I generally understand that and accept that as a point. But this concept of stopping to do pelvic exams on this patient completely, to me, seems totally ridiculous. It seems way out of left field. It goes sort of against everything I know, because what if you find an open os? What if you find POC? What if you find a lesion? What if you find a tear? Like, it seems like there's enough things, and this is a benign enough exam. We spent the whole morning, it felt like 14 hours, talking about CT scans and whether or not to get them, and the pros and cons. This is a pelvic exam. I personally believe, you know, granted I have never been pregnant. I don't know what that exam is like, but if you are pregnant and you show up as a patient into the emergency department and that you're bleeding and the doctor says, hey, I need to take a look and see and make sure everything's okay, I don't think a patient's going to say, whoa, 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 this seems way out of left field. I'm not so sure this exam is really warranted in this situation. I mean, I can't imagine any resistance from the patient side. I feel like it has a potential of giving me a good upside, of giving me some good information, even though I know most of the time it's not going to change my management. I think I do a lot more innocuous, or I guess more harmful things than this to patients to really stress out too much about this particular topic. That's one man's opinion. If somebody else wants to argue the con point, they can try. Go ahead, con me. And this is pregnant vag bleeders you're talking about, or just all vag bleeders? Okay, so, this is a point for those of you who couldn't hear was he's been practicing now for 10 years. He's never once seen a case where the exam really made that much of a difference. And that's, like I said, that's your practice. But I've seen a lot of cases where there was sort of an open os. And does that change my particular management of the patient? No, it absolutely doesn't. I'm going to send him home for a beta check. But it certainly it affects the way that I talk to the patient, tell them how I feel like, hey, the chance of your pregnancy not going well is a little bit higher than I would have known just from the ultrasound. So, correct. We're talking about speculum exams here. So, but if you're doing one, you're doing the other, at least in a pregnant vag bleeder, at least in my book. Now, the utility of speculum exam in general, I think, is a whole nother topic that we could discuss. Like some people say, everybody who comes in with abdominal pain needs like a pelvic and speculum and all this stuff, and I tend to not believe those things. But for me, bleeding, it doesn't quite sit right. Like there is something specific that's bleeding, and it just doesn't sit well in my gut to not look and see what's going on in there, because I feel like sometimes you could find something. But there are plenty of people who argue the other point, and I'm not going to say my opinion's right or wrong. It's just unfortunate, because I'm the one with the microphone, so it's going to be a little louder than your opinion. Go ahead. Sure, I mean, it's one of those things where, so his point was, there's a lot of logistical considerations too, getting a chaperone, setting up the room, doing all that stuff, which can be time consuming. So it's up to you to decide if this is a clinically important thing to do or not. And if it is, then it's worth taking the time. And if it isn't, then you can sort of make decisions based a little more on logistics. Did somebody else here have a? Okay, so point being, the question there was, or the statement was, maybe worth getting ultrasound first to find like placental location in case you're gonna like accidentally disrupt it when you try to shove your finger up the os or something like that. I think that's reasonable. These are pretty early pregnancies we're talking about here. We're really focusing on very early pregnancies, but in a later term patient, I think that becomes more of a concern, but an excellent point. Yeah, I'm completely of the same belief as you. This man is lucky enough to only work night shifts. I don't know if you guys want to find out how to do that, his secret. Maybe you can ask him. But I agree that sometimes you do find things that change your management. This seems like a useful test to me, but obviously it's debatable because there's quite a bit of literature says that it's not. So the next abstract number 21, talks about getting a formal ultrasound versus doing your own ultrasound for these patients, because they need an ultrasound, no question about that. So how many people here are doing their own ultrasound in isolation? That's it, own ultrasound and then sending them home. So hardly anybody. So most of them go for formal. This is kind of an interesting abstract. It's done by Tim Jang, who was an attending up at All of You, which is just up the road, probably about 30 miles north of here. And he looked at basically kind of what the learning curve looks like for doing your own ultrasounds. So those of you who don't do them, which is the vast majority of people in this room, why don't you do your own ultrasound? Okay, well, that's a problem. So if you don't have the probe, it's not an option. Certainly don't want to put the abdominal probe on there. That wouldn't make much sense. How, I agree with that. So it's time, it's a matter of convenience. There's a lot of different reasons why people don't do their own, but what they were looking at here is just sort of more of an accuracy issue. And that is to say, are we as good at doing this as an ultrasound tech, right? Which is a fair question. I generally believe that a doctor can probably learn whatever it is that an ultrasound tech needs to learn. And what they looked at here was sort of what does that learning curve look like? And what they found was, this is pretty everyone's seated, right? Okay, good. So the more ultrasounds you do, the more likely you are to agree with the formal radiologist's ultrasound. Ta-da, right? But they go on to give some numbers, which is a little bit strange. They give a number of 40. They say once you do 40 pelvic ultrasounds, you're golden. At 39, you're still a little bit slow on the take. But at 40, everybody really gets this. So conceptually, of course, I agree with this. The more tests we do, the more comfortable we're going to become with looking at the images and making some judgment calls, but I don't believe there's any magic about the number 40. Number 22, questions?
They may have done that because, see, in credential, they like to put a number of procedures done.
Right, so a point from the front was that may have just been a credentialing thing. At all of you, it isn't, but that's a good point. Like they may have tried to come up with a number just to say, hey, for credentialing purposes, if you want to use a number, this number of 40 is a pretty good number. Yeah, and I think this will come as no shock to you to know that Tim Jang is a trained ultrasonographer who has advanced training in this, and there are those of us who love ultrasound and there are those of us who don't really like ultrasound so much. I don't want to use the word hate, only because I don't want to seem like a hater, but I'm on that end of the spectrum. There's no question about that. I think we're getting a little too excited about the things that we can use ultrasound for and not really recognizing its both clinical and practical limitations. But abstract number 22, I think is just kind of more funny than anything else. It's called The Safety of Ultrasound in Pregnancy. So I, have not been practicing long enough to remember a day when people thought that ultrasound in pregnancy could actually be harmful to the fetus. Like those little ultrasound waves would like pound its little head in or something. I'm not sure exactly what they thought. Does anyone sort of remember those kinds of things? So yeah, it's like a reasonable amount of people in here actually thought that. And I understand that that used to be thought a long time ago, but I think it's very funny that this article is published in 2009, right? I think this question has been pretty well solved, in my opinion. And here they basically just looked at 41 different studies looking at ultrasound, and they looked at mom, they looked at sort of the perinatal period, and they followed these kids out to see if they all developed normal milestones, et cetera, et cetera. And there is no harm from doing ultrasound in pregnancy. It is safe for mom, it is safe for baby. But another funny thing about this is that every time you start looking for associations, eventually you'll find something, right? And they did find something. They found that patients, moms, who got more ultrasounds during pregnancy than those who did not, so just the number was increased, there was one thing different about their kids. Anybody have any idea what this could be? And just goes to show you how funny statistics can be, because you always find something. There's an increased risk of being left-handed. Right? So look hard enough and you're going to find something. That's what the numbers say. So the next section here is about a really important concept in evaluating the first trimester bleeder, which is the discriminatory zone of quantitative beta HCG measurements. So what is the discriminatory zone? This thing on? Sorry, hold on. Let me ask one more time. What is the discriminatory zone? I know the answer. Come on, guys. Okay, so the discriminatory zone, I'm going to add a little something onto that definition. is the number, the beta HCG number at which you should be able to see evidence of a viable intrauterine pregnancy. Okay, and that second part of the definition is really, really important because there are certain things we know about ectopic pregnancies. And one of the things we know about ectopic pregnancies is they produce beta HCG at a rate that is lower than that of an intrauterine pregnancy. And this is critically important to your workup of the patient where you're trying to rule out ectopic pregnancy, because you may run into a situation where, I am very lucky. I work at a place where we have ultrasonographers there 24/7, multiple of them dedicated just to the emergency department, but I get it that is weird. That is not the practice environment that most of you see, right? If you have to get an ultrasound at 3 in the morning, how easy is that? Ranges from mild pain in the ass to huge pain. Where in the spectrum of pain is it? Huge. Okay, so what you'll get occasionally is you'll get some kickback from these radiologists or these techs, where they'll say like, okay, this patient comes in with vaginal bleeding and they have a beta HCG of, let's say, 1,000. And you feel like they look a little bit sick, and you want to get an ultrasound, you may occasionally run into somebody who knows a little bit about the literature and a little bit about medicine, but not quite enough. And they'll say 1,000, well, that's not above the discriminatory zone. I'm not going to be able to see anything anyways. There's just no point. I don't need to come in, right? And that's when you need to know this answer. The secondary part of that is, yeah, but that number really only applies to intrauterine pregnancies, and I'm not worried about an intrauterine pregnancy here. That's why I'm calling you, is because I need to rule out something else. So understanding what the discriminatory zone is very, very important. Abstract number 23 is a very weird abstract. It's the use of beta HCG discriminatory zone with bedside pelvic ultrasound, and this was done up at UCSF. And basically what they did here was they took a cohort of women, all of whom had a beta HCG over 3,000. Right, so whatever your discriminatory zone is at your hospital, usually it's somewhere between 1,250 and 1,500. We can all agree that 3,000 is high enough, as to where we should be able to see something. And what they found in this cohort of women is that only a third of them, an intrauterine pregnancy was not seen in 1/3 of the patients. So it was only seen in 2/3 of this group, who we say, like, you should definitely be able to see something. And only 1/3 of that 1/3 went on to develop an ectopic. But they make a lot of statements here that I'm just find very hard to believe. There was a good portion of the women who had a beta HCG of 10,000 in whom they didn't see anything on the ultrasound. So what do you do with this piece of paper? I have no idea. I think you buy them a new ultrasound machine or something, because I don't know how to explain these findings. I have absolutely no idea, but the abstract is here, so I guess I had to mention it. And the last couple of abstracts here are about ruptured ectopics. So we definitely want to know if a patient has an ectopic pregnancy, but if they have a ruptured ectopic, this is a bigger deal. This is a much more significant patient, and what they're asking here is, how easy is it to clinically distinguish between an ectopic pregnancy that has ruptured and an ectopic pregnancy that has not ruptured? And is there any really easy clinical way to do this? The answer is no. Sometimes it can be very obvious. I can think of a few ruptured ectopic pregnancies in my career where they are incredibly sick. They are having heavy vaginal bleeding. They're hypotensive. Now, they may not be tachycardic, right, because there is that paradoxical bradycardia that you can see with ruptured ectopic pregnancies, but they're really sick. You may have an ultrasound that you just put on their belly, you see fluid everywhere, you're like, okay, this is a ruptured ectopic, I get it. But most of the time, they're much more subtle than that. So both these two papers here are looking at something called the shock index, and saying, well, let's take a look at something called the shock index and see if this is any better at predicting whether or not an ectopic pregnancy has ruptured or not. And for those of you who don't routinely calculate shock index on every single patient, like I'm sure you probably do, the shock index is basically just your heart rate over your systolic blood pressure, and a normal value is about 0.5. And what they found in these papers, and they were looking at just sort of, does the shock index work better than looking at are they hypotensive, are they tachycardic, et cetera? And they found that it did work just the tiniest smidgen bit better, but I probably think it's not worth it to try to remember what this thing is and actually use it. Just know that ruptured ectopics can be very difficult to clinically distinguish from a non-ruptured ectopic. And those are the only abstracts in this section. It's actually really short. They sort of have a list of fun facts, I will call them, I guess, at the end of the chapter, which we can go through some of the more fun ones. Some we already did, knowing about the discriminatory zone and knowing that about half of ectopic pregnancies that you can see something on ultrasound, like an adnexal mass, will have a beta HCG level of less than 1,000, so under the discriminatory zone. So know that. They produce beta HCG at a different rate. Another thing I think is worth knowing about is the doubling rate of beta HCG, right? So if we send a patient out for a beta check, it should double within 48 to 72 hours. And if it doesn't, then something is going wrong. And the last little section here I want to talk about a little bit is methotrexate. So basically, who can get methotrexate? Who are candidates for getting methotrexate in the emergency department if an ectopic pregnancy is developed? There's only a few criteria. 1, hemodynamically stable. 2, beta HCG less than 5,000. 3, ectopic pregnancy size of less than 3 to 4 centimeters. And this will be dependent on what your hospital guidelines are. But the fourth one, I think, is the most important of all, and that is the patient has good ability to return to the emergency department if something was to go wrong. Right? Now, it would be very uncommon for you to sort of cowboy make the decision to give an ectopic pregnancy methotrexate without calling your OB-GYN people first, but I think you should know these 4 things at least simply, so when you're talking to your patient and waiting for them to call back, you can sort of give them the go-ahead, say, hey, you know what, this is what's going to happen, but this is a situation which likely we can have some medical management for. So it's worth knowing those things. And you can't get methotrexate, obviously, if you're hemodynamically unstable, if you have evidence of ruptured ectopic, or if the patient can't follow up. So how well does methotrexate work for ectopic pregnancy? 1 dose of methotrexate works about 85% of the time. So it's a very effective drug if given to the right patient. And the last thing I want to mention is, and we do see this, what if you see a patient in the emergency department who got a dose of methotrexate and is now returning with abdominal pain? What do you do? Because this definitely happens. So what you do is very dependent on the time frame after methotrexate. So methotrexate typically does cause abdominal pain, but it doesn't cause abdominal pain until further out in the course of things. We're talking 5, 6, 7 days. That can be attributed to methotrexate. If a patient got methotrexate in the emergency department yesterday, or in the OB's office yesterday, or wherever it is, and is now coming in with abdominal pain just 24 hours after, what's your concern in that patient? Rupture, right? So the critical thing there is time difference. I think what you just said hit the nail on the head. That's exactly right. And if I implied otherwise, please let me retract that statement. My point was that if they're coming in a day after, there's no way it can be the methotrexate. That's just far too soon. If a patient's coming in, whether it be 3 days after or 5 days after, what it does is it can increase or decrease your level of concern for ruptured ectopic. Having a ruptured ectopic come in a week after methotrexate would be a much more uncommon situation than it would a day after. So a day after, it can't be the methotrexate. Now, I'm not saying that if they come in a week after with abdominal pain and vomiting, you say like, oh, this is perfect timing, it's methotrexate, you get to go home. No ultrasound, definitely no pelvic exam, right? We don't do those anymore, we already decided. I'm definitely not trying to say that. I'm trying to say the chance of it being ruptured is significantly less further out, but thank you for letting me clarify that point. Any other questions to the exciting conclusion of Pregnancy Pearls Part 2? Oh, well, then I will pass it over to our grand leader, Rick. So the question, to repeat it for those of you who couldn't hear it, was, are there any sort of rules that you can sort of apply to what the beta HCG should look like if it's on the downslope, if this is a non-viable pregnancy? And the answer is no. There's nothing reliable, because it really has to do with the level of beta HCG that you started at, so how far along the pregnancy was, and the reason for the miscarriage. So it's all over the map, right? I mean, all we really have is to count on is the positive side, the knowing that it doubles every 2 to 3 days.